All right, awesome. Thanks everyone for coming. So I'm Jacob Marquette. I am a hospitalist with Barton, and I'm also an addiction medicine doctor. So primarily tonight we're going to run through a couple of things on just what addiction medicine is, and then how to access some of the treatment options in our sort of small town up here. Okay. So the first is sort of like understanding what addiction is and how kind of an addiction medicine doctor comes to this. And I would say there's multiple different types of addiction. And sort of something that needs to happen with that is that you have this sort of compulsive use despite harm. And that encompasses things like substances, behavioral disorders, and different sort of process dependencies. And that would be like microprocessor addiction, those kind of things. Um, so this is really coming from a pretty complex interaction. So psychological factors, environmental, and then this sort of creates this scenario for a person or a brain that is more vulnerable for substance use disorders or different type of addictive behaviors. Um, so really this happens through sort of a myriad of different signs and symptoms, and how do you kind of recognize this? And that's really going to be those behavioral changes, those repetitive behaviors, including cravings, neglect of responsibilities, and then having that sort of withdrawal scenario when you come out of that addictive behavior. I would say sort of some of the options when we look at them of really saying, what can we do for substance use disorders and different sort of addictions? And really sort of one of the primary things is going to be medications that we can use. So on the next slide, we'll go through what some of those are for different use disorders, but realizing that like medications can only get you so far with things. They are usually going to be combined with some sort of behavioral therapy. So whether that is sort of dialectical or cognitive behavioral therapy, that's really something that we should be focusing on in conjunction with medications. And specifically, sort of behavioral therapy is going to focus on how you sort of modify those harmful behaviors and develop coping mechanisms to support your recovery, but also sort of like how do you come out of a life of substance use and start to develop like what your other interests and modes of behavior look like. And then part of that and sort of coming off of that is really sort of what does that sort of new life look like? And that is really going to be through like support groups. So if you're kind of combining all these things between medications, behavioral therapy to develop that, and then support groups within the community to sort of like extend that recovery and say, like, once you have sort of developed those initial stages of it, how do you sort of find other people that have gone through this process? And what does their life look like after substance use? So I think that it's it's nice to sort of hit on what are some of the big use disorders that we deal with, kind of within the hospital setting and in the clinic, and sort of the bigger four that have medications associated with them, but like I said earlier, also going to be combined with behavioral therapies. So the first one to hit on would be opioid use disorder. I think that this has developed a lot, even in the last couple of years, on kind of what medications we use. And so primarily it's going to be buprenorphine based or sort of like partial agonists. And so that's something that's going to bind those opioid receptors, but not fully activate them. This is going to be something that will reduce cravings for opioids, but has a higher safety profile than sort of full opioids, because you're not going to get the same amount of respiratory suppression that you would with those sort of full opioids. And when we think about buprenorphine, we should really think about it in sort of like two different parts, whether that is something that someone is taking through a pill or a sublingual film, and then something that someone is getting a long acting injectable for. So I think the idea there is that we have better access, especially like within our community, because of a lot of the work that's been done to get those medications accessible within the emergency department, within the hospital, and within clinic, especially in sort of like same day scenarios. And what that means is that if you are putting someone on to a weekly or monthly long acting injectable, like you are providing them with a much lower risk of opioid intoxication and overdose within that time frame. And we really know that that does save lives. So the other ones in that class are sort of methadone and naltrexone. Methadone is really sort of a near full opioid agonist. It's just really long acting. And so that's why it's classically been used sort of in the clinic scenario. And there's really sort of some pretty extensive restrictions on how that can be used. And that's why it's mainly within opioid treatment programs, also sort of known as methadone clinics. And the last one in that group is going to be naltrexone. So this is an opioid antagonist. So it's going to block the effects of opioids. What we really know is that that sort of changes how the brain then sort of responds. And that is going to sort of bring some amount of balance, but really be there to reduce the rewarding effects of an opioid when you're on that medication. And that is something that we do know is effective, but it is not as effective as sort of like the oral and sublingual forms of buprenorphine and the actual opioids, as well as far less sort of effective longer term than the long acting injectables. Sort of the next one, and primarily one that we deal with a lot in our area, is going to be alcohol use disorder. I think we have three main medications that we use in the US for this. This is really going to be sort of two that we use quite a bit, and one that's sort of fallen somewhat out of favor. So disulfiram or antabuse is one that people have used in the past. It is somewhat of a punitive medication in that if you take it, you are inhibiting alcohol dehydrogenase, and therefore when you drink on top of it, you get a pretty unpleasant reaction, and that can be some amount of vomiting and dysphoria. I think we don't use that very often. Acamprosate is another one that we use that helps with that sort of craving pathway within the brain, but it is a high pill burden. It's usually going to be 2 pills 3 times a day. And then naltrexone, the main one we use, so that's going to be either a pill once a day, or again, like we put you on a monthly injectable, so a long-acting injectable formulation of that. And this is like our primary medication, and it's going to work again by sort of reducing the rewarding effects of alcohol and reducing cravings and that sort of pathway in our brain. The last two to start with, tobacco use, is really sort of one that still is something that has a very high mortality rate long term, and is associated with kind of its effects on the most deaths in the United States. So the first one on here is going to be nicotine replacement. Then we have bupropion and varenicline or Chantix. I would say primarily what we're trying to do is sort of cover our nicotine receptors in multiple ways. So ideally, we're using varenicline or Chantix. So that's again going to be a partial nicotine agonist, where it is going to bind those nicotine receptors, but have a pretty complex interaction there, so that it is somewhat activating, somewhat blocking them from nicotine binding when someone smokes a cigarette. So you kind of get this feeling that you have had a small puff off a cigarette throughout the day. We usually want to replace some amount of nicotine, usually through a patch, so something that someone wears 24 hours a day. And then also on top of that, give them access to something like gum, lozenge, or a nasal spray. And we can also use bupropion in the place of Chantix if someone is not really tolerating that medication. What I would say is sort of we've seen a need to be using these sort of three modalities of a Chantix based with a nicotine patch and then also like a short acting nicotine in conjunction, sort of as nicotine concentrations within cigarettes rise, plus also people are vaping and therefore getting more nicotine in their system. I think that from a cigarette, you absorb around 10 to 20% of the nicotine within a cigarette, which can range from about 8 to 20 milligrams. And from vaping, you can get anywhere from around like 30 to 50% of the nicotine from vaping. And so clearly, people can take in quite a bit more nicotine during the day from vaping. And we have to really take that into account when we're trying to sort of calculate how much they should be using as far as like nicotine replacement as they're coming off to really sort of support that success. Um, as far as stimulants go, I think that we still have, being a more rural area, we still have kind of everything that comes along with rural destitution, and that is stimulants, mainly sort of like methamphetamine. At this point, there's no medications that the FDA specifically approves for that, but we do use some in different scenarios. That's going to be bupropion, naltrexone, and mirtazapine or Remeron. And those are medications that can help in some specific scenarios. And then we still do some amount of stimulant replacement, and that's modafinil that you see on there. And how we use those is pretty structured, and is different from sort of treatment of ADHD and other problems like that. But what we're really trying to do is make sure that they have connections to cognitive and dialectical behavioral therapy. And then if we can get them into some amount of contingency management, which is really going to be sort of providing them with the opportunity to still be coming into medical visits, but being rewarded for that type of change in behavior. So these are sort of the behavioral modalities that we rely upon. Big one's going to be cognitive behavioral therapy. We talked about dialectical behavioral therapy. But this is sort of like, how do you change, like identify and change those thought patterns to something new from what you were doing for substance uses previously. Motivational interviewing is usually kind of what myself or the psychologist or therapist will do when they get into clinic. And that's really sort of talking about how do you sort of, again, use some of those cognitive behavioral therapy techniques, but how do you sort of explore what a new lifestyle can look like, and present some advantages to that. All right. So then we talked about pretty early on that groups and peer networks are going to be really important as someone sort of transitions a lifestyle. And that is important here to say, how do you sort of support yourself in a way that you can get through the initial phases, but then realizing that there may always be those scenarios that kind of put you into substance use, and how do you sort of reformulate what your lifestyle can look like, and how that your focus can be different. And learning from people that have been through that is a really important part of that process. I think that what you've already sort of seen is there is a cadre of medications that we can use. Those have benefits, but they are not a panacea. I think that these have to be really personalized to sort of say, what use disorder do we see? What medications can we use to assist, especially with sort of like decreasing morbidity and mortality or early on? But then also sort of transitioning some of those behavioral therapy techniques to say, how do we sort of form what this lifestyle can look like after substance use? And then I think that it's important to understand that access is different in different areas. I think we've worked really hard um, to sort of set up how people can access this appropriately in our small town, but still have access to medications, like addiction medicine physicians, like substance use navigators, and different clinicians in a way that is hopefully kind of, I would say, hitting above our weight for like our small area here. And I would say one of the big things that's been done, primarily pioneered with one of our emergency room physicians that also works in clinic, has been access to our substance use navigators. And I think Natasha will drop that in the chat and send that out after. That's going to be most people's sort of primary access to this, to say, if I am someone who at this point has myself, a family member, or someone that I know, how do I get them best access to this? I think that you don't have to understand sort of like the intricacies of the US medical system, especially in a rural area. That is going to be your tie there, is really those substance use navigators. I think that places that people can access it is through Barton Community Health Center. Your primary care can get you in, and then through the emergency room for like more severe events with this are really good ways to go. I think that talking through sort of like what the role of a community is in this is huge, is sort of saying that we decide like what the face of this looks like to people that are presenting, and how we reduce stigma and get more people into the care that they need to live healthier lifestyles is really important. And realizing that substance use disorders are really sort of a chronic health condition and not just a moral failing. And that we really do see, once people have had access to evidence-based medications, appropriate behavioral therapy, that this can really be sort of life-changing for them. Right. So that should be the end of things. And then um, I'll stop sharing, and then I'll let Natasha kind of answer some questions that may have been put in.
Yeah, thank you so much. I, if you missed the introduction in the beginning, Dr. Marquette will take questions. You can enter them into the Q&A box at the bottom of your Zoom screen or the chat. And while I wait to see those come in, Dr. Marquette, can you just give a little bit of an overview of what your board certification in addiction medicine looks like? What does that mean for the community having you here with that?
Yeah. I mean, so at this point, um, like I'm the only addiction boarded physician in a pretty good span. Like we have Dr. Elizabeth McNamara and then Dr. Grace Harding that are both getting very close to reaching their board certification in addiction medicine. So that's something we've had a real focus on, to sort of say, how do we provide the expertise for this, because we've focused on this as something that really needs to change, like within our health system and our community. Um, and so I think, what does that mean overall? So I am also on staff at Tahoe Forest to sort of help with the same. And then it's a pretty um, distant area to get to like another addiction physician at this point. Um, and I think that that means that we have had the ability with this group of people here at Barton that are really passionate about this to sort of build better evidence-based medication access, plus the expertise to sort of put that in throughout the health system, whether that's in clinic, in the emergency department, inpatient in the hospital, and what that looks like so that we can get people more access to higher level care modalities.
Great. And I think just going back to the access that you were discussing, if someone is concerned about a loved one, and maybe it's not during regular business hours, can you just describe like the pathway? I mean, I'm assuming they would go to the emergency department, and then what would happen?
Yeah. So, I mean, that obviously kind of depends on like the severity and the use disorder going on. But that's part of it is I think that reaching out to our substance use navigators when they're on, Dr. McNamara is doing an excellent job to sort of expand that service to now looking at coming up on 7 days a week for coverage for that. And then those are returned pretty quickly. So if that's someone where someone needs access within sort of a few hours to a few days, sort of thing, that's a great way to go. If these are things where these are sort of like emergencies at that point with withdrawal, those kind of things, like that's through the emergency department. And I think that we also communicate pretty closely with our substance use navigators to try and get people into clinic as quickly as possible. A lot of times that can sort of be within the same day to the same sort of over the next 3 days is what we really shoot for.
Great. We do have a question that's come in. Just this person has a son that has SUD and then also alcoholism, but they only have Medi-Cal. Is that something that we can treat with Medi-Cal insurance?
Yeah, for sure. I would say that Medi-Cal is actually going to be an awesome insurance for coverage of all of this. I mean, for that person in particular, just reaching out through the substance use navigators is going to be the way to go. I think that Barton Community Health Center is our rural health center, which means that we cover all people that have Medicaid, Medi-Cal, and are uninsured.
And can you describe what the treatment looks like long term? Is this something that once they are going on the MAT program, that they would be on that lifelong? Like, what are those
Yeah,
pathways look like?
I mean, that's variable. I would say that most of the evidence is going to be that we want at least a good amount of time on these medications. A lot of them can be lifelong. That's sort of up to the clinician and the person um, that is being treated. But I think we have stronger evidence that there it takes a significant amount of time to sort of have those changes in the brain take place, have that sort of behavioral therapy take effect, and have some of those sort of life altering experiences enough that someone is sort of ready for that. And I think there were pushes in the past to sort of get people off of these medications somewhat early. And really, we saw um, not a lot good come out of that. So I would say plenty of these can be lifelong, and in many people's case are, but it's always revisited. The goal is not to sort of medicate people for life. The goal is to sort of like have them get some amount of sustained remission and have some amount of behavioral therapy on board, and then have those discussions pretty frequently.
And can you talk to us about adolescents or teens? You talked about tobacco being something that can be addressed, alcohol, and what would that look like for our minors in our community?
Yeah, I mean, so I think that there's always a push to not sort of treat children like small adults. But in these scenarios, like the medications that we use are very similar. And we have to think about what the risk benefit is. So I think that we really have a tremendously larger amount of people under the age of 18 that have access to higher dose nicotine at a younger age. That's usually going to be through like e-cigarettes and vaping. So I think that we still want to figure out how we use those medications and get them into behavioral therapy to reduce that use pattern. And so a lot of those things are going to be similar, especially as you step into alcohol and then also into opioids. Like you have to think about what is the risk and the benefit of using those treatments. And I think that the benefit profile for a lot of those medications that we use in those scenarios for both alcohol and for opioids is going to be very similar for minors as well. So we still use plenty of those medications there.
We have another good question asking about dual diagnosis with bipolar mental illness. What's the approach for treatment that way?
Yeah. I mean, we have, I would say, as a rural area, again, like these are sort of intricate, it's complex, but these are things that if we can pull people into care um, in a way that they are able to sort of be maintained in care for both mental illness and substance use disorders, like that's what our goal is. And I think that we at this point in our area don't have amazing access through kind of um, just the complex interplay of how you sort of like have a psychiatrist in the area in person. And so like access is always going to be hard there. I think what we do try and do is figure out how you sort of stabilize a substance use disorder and then be able to provide that person access to medications for their mental illness. And I think that we are able to do that in a lot of fruitful ways just in when we're seeing someone for a substance use disorder. But our goal is to sort of like be able to treat those in unison. And if we are using sort of like for more severe mental illness, can we be getting someone on two long acting injectables at the same time to treat both of those? Like we really try and figure out how we find these people the most stability within that realm.
Great. And I'm gonna include in the chat a YouTube link to a webinar that Dr. McNamara did earlier this year about co-occurring disorders. So please do feel welcome to watch that if you want to learn more about that. Um, I'm not seeing any other questions come through, so I'm going to start to wrap it up, but I will keep an eye. If you do have a question you want to ask, I'll be sure to ask it for you. But this has been recorded, so if you want to reference back, it will be on our YouTube channel and our Facebook channel. And at the conclusion of tonight's webinar, there will be a very short survey. We want to hear how we're doing, and if you have any topics that would be of interest in the future, that would definitely be something we want to learn more about. So I'm looking and I don't see any other questions. And yeah, I think we kept this short and sweet, but I thought that was really good and appreciate you being here tonight, Dr. Marquette. So I hope everyone enjoys the rest of their evening and we'll see you next time. Thanks
All
so
right. Thanks
much.
for the time.